Hi, everyone. We're back. We're just about 2 or 3 minutes behind our schedule, just to make sure that all our panelists are on. Our next session is going to be looking at how correctional care physicians actually have been managing the pandemic inside. I don't need to tell those who've been covering this issue in the criminal justice sphere that how deeply COVID has impacted correctional care as well as the rest of the justice system. That's not always obvious in all the reporting and justified concern about how COVID is wreaking havoc across the U.S. But it's well to remember that the correctional system, jails and prisons in particular, are along with nursing homes the hot zones really for the pandemic and have been the hot zones for the pandemic so far. It's taken a huge toll on incarcerees, but also on families and staff. And those who are at the center of dealing with the issue are, of course, the physicians themselves. So we're really pleased to have some reports from the front lines. And I want to start with Emily Wang, who has just been part of a major report done by the National Academies of Sciences to look at how COVID-19 has affected the whole process of decarceration. So let me put Emily on, and she'll be speaking first, and then we'll have Dr. John May on next. So Emily, let me send the curtain over to you, the gavel over to you. Welcome to our webinar program. You're on, Emily.
Great. I'm just seeing a flag right here. So thank you so much. I really appreciate the opportunity to be here. And should I just go ahead and start speaking?
Yes, please. Yes.
Oh, okay, great. So, I'll start by just introducing myself and giving a little bit of context to who I am. And I see Michael, giving updates on this side. I mostly identify, I don't practice medicine within prisons and jails. I'm a primary care physician who for the past decade has focused on the care of people that are transitioning home from jails and prisons within Transitions Clinic Network. And in doing that, though, the large part of my work is really focused on how best to improve the health of these individuals, these patients that come home, but also their family members and communities. And so just recently, as you alluded to, had the opportunity to co-chair National Academies of Sciences consensus report, one of just a handful that have come out during the COVID pandemic, specifically focused on decarcerating correctional facilities during COVID. I co-chaired that consensus report with Bruce Western and a real diverse group of scholars and also practitioners. And I think it's important to note that Secretary John Wetzel of the Department of Corrections was a member of our committee, as well as Deanna Hoskins, who's a real leader in centering the policies currently around the needs, voices, and perspectives of those who are currently or formerly incarcerated. And so it's with that framework that I just wanted to touch on both, and I'll really try to center, what it is that the committee decided within our consensus report, and then also share with you some impressions that I've had during the pandemic of caring for my own patients that have returned home from corrections. And I understand, I'm looking at you, Michael, I probably have 10 minutes, hopefully less.
Yes, 10, 12 minutes, take what you need.
Okay, sounds good. So, again, as you were alluding to, it doesn't come as any surprise. Prior to the opening of universities, I would say, if you looked at the New York Times list, 90 of the top 100 large cluster outbreaks, so larger than 1,000 cases, took place in our nation's correctional facilities, so in our prisons and jails. And there have been a handful of reports that have indicated, again, that correctional officers, staff, as well as, of course, those that are incarcerated, have been disproportionately impacted by the COVID-19 pandemic. And so there was a study that came out in JAMA that showed that staff as well as incarcerated individuals had about a 3 to 5 times increased risk of getting COVID, and this they adjusted for age, race, and gender, and then have also had an increased risk of dying from COVID. And so it is not surprisingly, as oftentimes respiratory outbreaks have done in the past historically and now, concentrated within our correctional facilities. And, in looking at the emerging literature or recently published literature, I think it's often in our notions that, well, this is just an issue of corrections, right? It's those that are incarcerated, those that work there. But in fact, there have been reports showing that what happens within correctional facilities is also very much tied to transmission within communities. And so there have been studies also, both in the preprint but in the published literature, that have shown that it's the in and out of jails in particular. This one study was focused on jails, that found that the throughput in an urban jail, so the in and out in an urban jail, was associated with anywhere from about 16% of the cases within the zip codes of Chicago, and also within the state of Illinois, showing again this intersection, this interconnectivity that you got to care about corrections if you care about community rates, and vice versa. And so it's in that setting that we embarked on this consensus report that was funded by the Robert Wood Johnson Foundation, as well as Arnold Ventures, and really focused in on asking, what are the evidence-based practices for decarceration, for depopulating correctional facilities, prisons, and jails, and what sort of community supports ought to be leveraged to support that decarceration, all in the time of COVID. And so within the consensus report, what we first did was looked again at the either past literature or current literature, identifying that there are any number of factors that really put correctional facilities at high risks for COVID-19 transmission. And, for those of you that have stepped foot into a prison or jail, you'll know that, these are set systems and settings that often, haven't gone large remodeling. The physical plant in and of itself can be old. The systems of ventilation is old, and Dr. May will speak much more clearly to that, I suspect. But correctional facilities at large, and there's 5,000 of them around the country, they're very variable in their design and their construction. They're also very variable in how they house individuals and what the facility can accommodate. And so there certainly are concerns of overcrowding. And in overcrowded spaces, then of course you can't appropriately physically distance individuals. But even in facilities that actually can single cell, so put individuals in their own cells, there are many opportunities to congregate. So, ranging from how people eat, how people make medication lines, how people access healthcare, how people exercise, et cetera. And so this interaction is one significant factor that led to increased COVID transmission in many correctional facilities across the country that we've seen through March until now. The second piece that we focus in on the consensus report is just this throughput, the in and out in jails. And so, jails, of course, are housing those that are awaiting adjudication of crime or serving sentences of, less than a year. And so they're where the large proportion of people are moving through the criminal justice system. And so it's this in and out. And it's this in and out that's largely concentrated in poor communities, and as well as communities where racial and ethnic minorities are disproportionately represented, that we see large swaths of individuals moving in and out of communities that are already challenged by COVID-19 and then coming into the correctional system. And so that was a second kind of feature of correctional systems that put them at increased risk, placing those that are incarcerated as well as those that work in there at increased risk. A third piece of this is just the increased rates of chronic health conditions that are common among people that are incarcerated and are also COVID-19 risk factors. So they include conditions like hypertension, heart disease, and asthma. And again, we see that it disproportionately affects incarcerated individuals and thus placing individuals at increased risk for COVID-19 transmission. And then fourthly, and I think importantly, and I'm certain that Dr. May will speak to this, is that, again, not new to COVID-19, but certainly strained now. And it really varies. So, like if you're talking about an urban jail versus a rural jail or a large state system, there's real heterogeneity across all the healthcare systems. But the healthcare delivery systems within correctional facilities are often entirely siloed from the community health systems. They're siloed from the public health infrastructure and siloed from pandemic preparedness. And so what this led to were certain correctional facilities that, again, once overwhelmed by the novel coronavirus, were unable to manage, mitigate, and prevent COVID-19 transmission. And so then our consensus report from these factors then starts examining decarceration. And so, that's depopulation either at the front end, so as people move in through jails, or at the back end as people are released, finishing their sentences in prisons. And for that piece, we centered our work on kind of some primary principles. First, of the need to really, on balance, evaluate the quality of evidence and evaluate it given, firstly, that within the pandemic, public safety is also very tied to public health and vice versa. Secondly, recognizing that a lens towards health equity in particular is important. So again, we know that correctional systems have disproportionately incarcerated poor people of color, and COVID-19 has disproportionately affected poor people of color, placing these two systems and settings at increased risk. And so our recommendations had a high attention towards how we might, importantly, either mitigate the disparities, the racial disparities, in our recommendations for decarceration, as well as the community supports that are provided to support decarceration. And then the third piece of it is really an important focus on transparency. So how it is that transparency of processes, transparency of data can lead to better public health and public safety. And so we evaluated studies looking at decarceration. And during COVID, there, again, the evidence changes with regularity. In this setting, there have been a few studies that our report highlights, one of which was produced out of our lab at Yale in partnership with researchers at Stanford. And again, here we took data from an anonymized urban jail and found and looked at daily incident cases among, again, incarcerated individuals as well as staff. And an important piece is that what we wanted to look at in that study was really focusing in on top of CDC guidance, does depopulation reduce transmission? On top of CDC guidance, does asymptomatic testing reduce transmission? And on top of CDC guidance, so, again, the jail's doing everything that they've been told to do to the best of their ability. And also, as many jails and prisons did across the country, tried, innovated, adapted other procedures that they thought would best promote safety from inside. It looked at single celling. And what we found in that study was that, in fact, depopulation, asymptomatic testing, and single celling all reduced COVID-19 transmission. So, reduced it from the initial kind of outbreak was at a point where the basic reproduction ratio, so what that is the number of individuals that will get an infection if one person's infected. So initially in that anonymized jail, for every one person that was infected, about 8 people were newly infected. And after instituting those 3 policies, the basic reproduction ratio went down to below 1. And so, those are important and key tools to be administering in addition to kind of wearing masks, sanitation, et cetera.
Dr. Wang, let me ask you, if I could, before we go on to Dr. May and other questions from the journalists, if you could move back a bit, take a 10,000-foot view. I mean, this is certainly the most serious pandemic we've been exposed to in a century, but it's not the first one that has hit the country. And I'm wondering whether you've been able to draw, and your colleagues have been able to draw any lessons for correctional care and how you handle these contagious disease outbreaks or similar health challenges inside the correctional system, and obviously how it relates to when people come outside. When people are released, they obviously pose dangers to their families and to the rest of the community. So, I mean, are there lessons you can draw? I mean, it's an open question whether the correctional care community has ever even thought about how to deal with pandemics before we've encountered this one.
Yeah, it's I guess where I started, which is that it's not a surprise that this pandemic has disproportionately affected correctional facilities. This has always been the case. There are reports in the literature of how the Spanish flu in the 1918s, right, kind of just decimated San Quentin. And so it's just by the very nature of how we've constructed correctional facilities and again, how they've propagated and built over time that here we are in COVID-19 with high rates of the coronavirus within correctional systems. I also think, within our consensus report, we do, one of our primary recommendations is that correctional facilities ought to be integrated within the public health infrastructure as key part and parcel of public health preparedness planning. And in certain jurisdictions, they were, and a large majority, they were not. And so that I think is a key piece, is that we're now seeing, and I give it as an example. So the National Academies also convened a consensus report on vaccine distribution, again, centering interestingly around health equity.
That was my next question about how you distribute the vaccines when they come.
Exactly. So, and in that, as you know, because you're already hinting at it, correctional facilities actually are in phase 2. So they come early. They recognize, the committee as a whole, that those that are incarcerated, those that work there, ought to be prioritized for vaccine distribution. And so, what I think is important is that there is this growing notion within the public health community, within the medical community, that we must, if we're thinking about all of our health, then we have to focus in on correctional health. And I will say then that, the devil's really in the details of how it is that gets implemented is really critically important of uptake, how it gets distributed. And I can, leave that question to Dr. May, who would know far better.
So let's leave it there for the moment, and let me, unless you have another thing you want to add.
I did want to just add this. So the report does highlight the different ways that we feel like decarceration has happened and where the barriers were. Okay. So, and also importantly, that a bundle of supports ought to be provided. And, in looking at kind of reports that have come out about decarceration, there's a lot of focus on the actual release. There was this executive in New Jersey, for instance, 2,000 people are released. And I think what I think is additive about the consensus report is what sorts of social supports need to be in place for the decarceration to actually be successful, to be longstanding. And we identified different ways that policies can be acted within the first even 100 days, right, in the domains of the new administration. We didn't focus on the new administration, but quickly in housing, healthcare, income supports, and those are critical to really supporting decarceration in the interest of our public health and public safety.
That's a really important point. I want to get back into that, about what the next steps are and the recommendations really for federal policy should be as a result of that. But let me I'll move on first to Dr. May, so he can add to the conversation, and then we'll go back to our question and answer period. Dr. May, the gavel is yours. Welcome.
Thank you. Good afternoon. I'm really honored to be part of this panel with Emily Wang. She's such a thought leader, and her colleagues there at Yale on this. And thank you for inviting me to participate, be part of this, this great, important topic. So just a brief history for me. I'm an internal medicine physician, been practicing in jails and prisons for nearly 30 years now in a variety of settings across the United States. So I'm speaking from that perspective as a correctional healthcare physician. I've got some slides to sort of provide an introduction to these topics. So we could bring up the slides, please. If Chris had them. I also want to thank the presentation before from Tom Weaver. I thought that was very good and touched on many of the issues that we see here. And finally, before I start, I want to acknowledge and thank my colleagues who work with me tirelessly every day on these issues. Brenda Sue Medley Lane, infection control nurse, really a national expert on what this pandemic means in corrections, and Dr. Johnny Wu, my colleague, my boss, who oversees our clinical operations for Centurion and has really been a steady hand through all of this. I want to start with a quote. Next slide, with one of the most famous former prisoners, Nelson Mandela, and recognizing that control is such an issue in corrections, and control in a time of pandemic where we all have lost control, right? We feel like we've lost control, but imagine being someone in custody in a jail or prison and what that means to lose control. And I think this quote from Nelson Mandela says it nicely, that our garden was one of the few things in prison that one could control. To plant a seed, watch it grow, to tend it, then harvest it, offered a simple but enduring satisfaction. The sense of being custodian of this small patch of earth offered a taste of freedom. So no doubt this is an unprecedented stressful time in corrections. It's for those who live in jails and prisons, for those who work in jails and prisons, certainly the health staff there and the custodial staff and all the support staff that are involved in the machinery of making a prison safe, secure, and functional. And then the families of all those persons, the families of those who are incarcerated, the families of those who go to work every day and come home to them. Let me start with the next slide. Again, on the issue of control and recognizing that indeed these are very vulnerable populations and that you don't have control so often. The CDC early on in the pandemic put out a list of folks who are at higher risk or need extra precautions because of their vulnerability to COVID. And to match that to what we see in jails and prisons is pretty astonishing. Certainly older persons, and that's our fastest growing segment within corrections. For persons with underlying medical conditions, as you've heard from both previous presenters, these indeed are overrepresented in jails and prisons. Persons of ethnic and racial minority groups, certainly, as we know, overrepresented in jails and prisons. Persons with disabilities, also overrepresented in jails and prisons. People with developmental and behavioral disorders, overrepresented in prisons. Pregnant people, and while maybe not overrepresented, certainly the pregnancies that do come in through jails and prisons are very high risk. They have multiple other conditions that make those pregnancies higher risk than most. And persons experiencing homelessness, again, overrepresented in prisons. The next slide, again, to the theme that you've been hearing so far today, that we have enormous challenges in corrections. So difficult to provide social distancing or the proper social distancing. As Emily spoke to before, some of the architectural design of the facilities built sometimes a century ago without attention to what the impact might be of a pandemic. The overcrowding that exists in many systems. So the depopulation efforts are so key to taking a handle on the epidemic. Recognize we have a high flow of staff in and out every single day, every shift. If COVID enters a facility, we say it comes through the front door, and certainly can come through new arrestees or new admissions to the prison, but more often it's coming in from staff who don't know it if they're asymptomatic and bring it into the facilities. Again, most jails and prisons are very dynamic. There are new admissions regularly, or transfer of people being released or sent out. So again, the flow, the throughput, again, as Dr. Wang had explained, some of the traditional measures that you might impact to reduce infection have to be reconsidered in a correctional environment, such as alcohol-based sanitizers. Some systems are able to use them successfully, others just do not, because certainly it poses a security risk, a fire risk, and other risks that have to be considered. So these accommodations have to be thought through, or what are the best solutions. There's been discussion of isolation and quarantine, and this is one of the biggest challenges, so that it does not become punitive. In fact, an isolation or quarantine in this setting is a therapy, and to make that experience as supportive as possible is very daunting. I mean, if anyone on the call has had to quarantine themselves, or it's just, as most of us are doing, limiting movement, it's very difficult. But imagine, doing it in often a cold room, or a thin mattress, or with all of your belongings. And then the enormous challenge of staff burnout, demoralization, and absenteeism, right? Some sites are really impacted by absenteeism. 10%, 20% of workforces out ill or on quarantine or due to exposure of a family member. And so the systems are operating with real limits. And gosh, 10 months into this, every single day, the burnout that happens, and the demoralization of, people who work in jails and prisons often are there for, as has been said before, because they have a mission to help and care for people. But recognizing that, there are bad things that happen due to the nature of everything involved, and when the public perception of that is not recognition of the efforts, the care that goes into caring for folks inside, but an accusation or feeling that things are falling apart, it's very demoralizing. You want to be part of a system that's successful, not one that's failing. And so this is something we have to constantly be in tune with for those of us working in jails or prisons. Dr. Wang also mentioned before about, and Tom Webster too, about community health programs outside of prisons. And that's an enormous challenge during this time, where hospitals or specialty clinics or specialists do not want to see patients coming from jails or prisons. And maybe we can speak to that later, but again, a challenge for corrections. So the next slide, very early on, there was a lot of readiness, and we've already talked before too about, past planning for infectious disease spreads and mitigation in correctional settings. Certainly nothing previous to this generation of something that we're experiencing now, but reducing populations is a key and first step that is being done. Reducing admissions, many prison systems, for example, put a hold on accepting new admissions from the county jails, right? Usually there's a transfer every day across this country of folks coming who've been sentenced in from county jails, admitting to statewide prison or federal prison systems. But there have been blocks on there. So this is causing backup sometimes in county jails, but is allowing things to be settled down in state prisons. But that can't last forever. And most systems now have opened that up or have staggered how new admissions work coming into systems. In-person visitations were stopped a long time ago, and again, with great impact. socialization is so important getting through these difficult times for persons at both ends. So alternatives such as video conferencing and others are implemented more and more. But as we all know, these Zoom calls, et cetera, are not the same as being in person, especially someone that you love. Symptom screening of all staff entering each shift. Imagine, around the clock every day for 10 months now. Have you lost your taste of smell or taste? Or coughing, fever, temperature checks, etc., happening all over the country every day. And of course, the key is though that you may not have symptoms and that you still could be carrying the virus and exposing others. Quarantine for new admissions, people coming into the facilities, a period of quarantine from others until they're determined safe to enter another housing area or general population area. Facial coverings for all staff, all incarcerated persons. There's not one universal plan across the whole United States. Each of the 50 states and other jurisdictions have their own regulations and measures, the federal system and the military prisons and immigration detention centers, whatever. Everyone has their own policies in place on this, but most require masking of staff. Most have offered masks to persons who are incarcerated. There's a limit to what you can make mandatory, particularly for persons who are incarcerated. And just imagine, none of us are likely to be wearing masks at home. And so when you're in a cell house or wherever, you're not going to be wearing masks. Other preparations for mitigation, again, cleaning surfaces, soap distribution, removing copay, which is a practice really universal throughout the US. Usually there's a small fee that becomes a big fee when you don't make any money, of course, that patients have to pay. Most systems have abolished that if you're complaining of a complaint that could be COVID, so that there's no disincentive to report. Increased use of telemedicine, we see that throughout the United States. Kiosks and tablets for use of incarcerated persons where you can communicate information, education, reporting of symptoms, etc. Medication deliveries, there's some newer innovative approaches. Instead of the patients lining up in long lines, where again, where social distancing might be hard, more are keeping their medications on person or in lockers or other means. We're having to round in all of the clinics where you have persons under quarantine or in isolation. Then if persons start getting sick with symptoms, they're usually moved to infirmary settings or of course to hospitalizations. And again, there are new barriers there. Again, as I mentioned before, sometimes hospitals don't even want to take persons who are sick coming out of prisons like this. So we have many clinical guidelines and protocols that have been developed on treating patients with COVID positive tests in corrections. We have been using remdesivir, and some of the prisons throughout the United States are designated hospitals, and so they're able to access remdesivir, which is a hospital-based medication, and provide it to patients in prisons. The newest monoclonal antibody just received emergency use authorization. Is being rolled out at several prisons now throughout the United States. These come through the public health departments, usually in close coordination with them. There's something called the Math Plus protocol, which is used in many hospitals as a adjunctive therapy, in addition to some medications like the steroids and anticoagulants and multiple vitamins, multiple types of vitamins being used for therapies for persons who may have COVID infections. And now the big attention turning to what's going to happen when the vaccine is available then and ready for distribution. How is that going to happen, and what will be the acceptance? We already have some sense that persons who are incarcerated are not so willing to take vaccinations. So this is our new challenge. Go to the next slide, please. So testing from day one has been such a challenge also. Again, Dr. Wang mentioned asymptomatic testing being one of the key strategies for reducing transmission and disease within corrections. And it's often so limited by what's available. So that there are approaches just for symptomatic testing. Persons who symptoms certainly should be tested or they're assumed positive and treated as such, versus asymptomatic testing approaches. You can do the mass testing where you test every single person, sometimes thousands within the facility. And imagine the effort and logistics going into an approach like that, but it's been done across the United States again and again. And then there's targeted asymptomatic testing, so contact tracing again, and that's a tool that corrections are quite used to, whether it's tuberculosis or chicken pox or other infectious disease outbreaks that require contact tracing. Testing out.
If I can just interrupt you for a second,
Sure.
I wanted to leave a lot of room for conversation and some questions.
Yes.
Could I ask you, just to focus back on the vaccine issue, which is obviously the one that's, that pretty much everybody is now thinking about in terms of the national and the general population. To your knowledge, have correctional care providers been told about what place they're going to have in the vaccine distribution, whichever company is going to be delivering them, and should they be a priority? Say like nursing homes in the targets of vaccination?
Yes, no, very, very good question. Well, Dr. Wang mentioned the guidance on equitable distribution of vaccine from the National Academy of Sciences. There's a phase 1A, which is to first responders, and there people working in jails and prisons or healthcare workers in jails and prisons are not specifically identified. It's a term of first responders, which includes, EMS personnel and hospital workers who are working close contact with COVID patients. So certainly we could make the argument that those, particularly healthcare workers in jails or prisons, ought to be part of that phase 1A, including people who are the custody officers working day to day with persons. But they're, again, as I mentioned, they're not specifically mentioned. Now, phase 1B mentions elderly persons in high congregate settings. So that would include nursing homes. And the final version of this draft, which came out last month, it mentions jails and prisons. So there, our patients who are elderly in high congregate settings would be part of phase 1B. And then as Dr. Wang mentioned, phase 2 rather, does mention those who work and live in jails and prisons. So all of the persons who are incarcerated and all of the staff. Now, our argument, and to your point, those who are really on the front lines taking care of the patients ought to be, we would argue, up to phase 1. And what we're finding now, again, this is early on, right? This distribution is really going to be led by the state health departments. And we've had some states reach out to us saying, we're going to include your health workers in our phase 1. We need the names of all the persons, and we're going to be shipping vaccines to your prison. And, so we want to know the quantities that need to be shipped. So they're part of that initial planning. There are other states that have not had that call out yet. So it's a hodgepodge.
So, I mean, that I can see a problem coming with that. And obviously, if journalists need to, reporting on this, and maybe Dr. Wang can come in on this question as well. Does there need to be a federal mandate to get this going? I mean, we've only got maybe 3 to 4 months before we start distributing the vaccines, and it's never been clear really what point and what level of priority should be given to particularly vulnerable populations like incarcerees and correctional systems.
Yeah, so I agree with the National Academy's recommendation that incarcerated individuals, those that work in corrections, exactly as Dr. May indicated, should be given high priority based on arguments of health equity, as well as kind of increased risk for COVID. There's no question. Whether or not this ought to be a federal mandate, I think is a tougher conversation. But, to me, what it speaks to, and there was a question in the Q&A as well, focused on that, is that, as you can see just by how Dr. May answered that question, there are state departments of public health that have already looked to directly integrated with the healthcare systems behind bars, and then others that haven't. And therein lies the issue with vaccines, same with testing. I mean, Dr. May was indicating this, some settings, yeah, you can get a test, but you're going to be kind of prioritized at the last. So you'll get it back 14 days later. Well, how useful is that for the correctional system? How useful is that for planning for release, quarantining at home, protecting your loved ones who are essential workers? So it is really important how the distribution of vaccines, of tests, even of masks, right, have happened, continue to happen, and even for future pandemics, happen in the future. And to me, the critical piece that isn't being discussed is, why hasn't corrections been integrated in all states? And, this isn't just the state prison systems, it's the local jails, in all public health preparedness. That's one of our recommendations.
Have either of you or any of your colleagues been in touch with the advisory committee that's been formed under President-elect Biden's transition team to discuss corrections as a target for as part of the strategy going forward? Do you know if it's been part of the strategy at all?
They are aware, yes.
That's a nice way of saying it.
I've not personally been involved, but I know there's been input from correctional health.
There has.
Interest. Mm-hmm.
Okay, well, let me move to some of the questions. Michael, can you read off the first question on our list? I think we've got two from Victoria Law. So the first one is a pretty long question for Victoria, and then there's a second one as well. So Michael, go ahead and read them.
Yeah, sure. Thank you. So Victoria Law, who is a freelance journalist, would like to know, how do you ensure that staff are not exposing incarcerated individuals to COVID-19? Is there daily testing of staff members? If staff members refuse to wear masks or to wear them properly, does Centurion have any authority to require them to do so? Have there been times that jail or prison officials have clashed with Centurion medical staff on best practices or medical care during the pandemic? And if so, how have these clashes been handled?
And then there's a second one for you. So that's a story in itself, I think. But answer what you can. And if you have more details, we can just put them in black and white and send them around to our journalists afterwards.
Sure. Well, a company, as actually Tom mentioned before, it has the ability to mandate those sorts of protections for its staff. So we have made it mandatory that all staff while in facilities wear masks. It's interesting. It is a bit awkward. There's moments when, say, a healthcare staff might approach someone who's not part of their company, who's not wearing a mask, and particularly if it's a correctional officer, someone that you have a relationship with, right, and independent worker who's not wearing a mask not properly, it creates some tense moments. And so again, we provide support to the field, we provide signage and education and bump it up, and we have regular meetings with the superintendents, whatever. It is the expectation in most systems where we work. It is, of course, the expectation also for the custody staff to be wearing masks and a personal protective equipment. So if that answers that, it's a challenge, no doubt, but all staff are required to wear masks. To the issue of testing, no, it's just not possible to test everybody every single day coming in and out of the facilities. I mean, there's just the volume, and as again Emily mentioned, sometimes unless you have point of care testing where you can get a result within a few minutes, even that is very cumbersome. It's not like you wait 30 seconds, you're done. It's quite a process. Some of these tests take, depending on what's happening in the community, 10 days or more to get a result. And so, meanwhile, yeah, or longer. So it's really an enormous challenge. The point of care testing would be such a game changer. And even though that would still have some kind of limits. So apart from that then the expectations are, again, attention to personal protective equipment. I mean, there's been some pretty remarkable articles. There was one MMWR which showed a hairstylist who both were infected, and they had over 130 clients before realizing they were infected, and none of their clients were infected because everyone was wearing masks. And so there is power in maintaining and wearing personal protective equipment, going through facilities and that. But any of our staff who are working directly with patients would have full PPE provided and expected to be worn. But testing is done regularly for staff. Again, some systems make it mandatory at certain intervals. Some make it voluntary, but it's accessible to staff. And it's important to do at least prevalence testing periodically, right, to check to see if, because you do identify then asymptomatic persons who may be positive. But again, as long as they're wearing their PPE and that, the risk to others is really minimal.
Thank you, Dr. May. So before I go to, yes, sorry, did you have more to?
It looked like she was wanted to say something to it. Emily
Yes.
did. Okay.
Well, before there's another question from Victoria, which hinges on decarceration issues. Before I go to that one, I wanted to go back to the vaccination question. There's a question from Claire Goforth, who asked whether there's been pushback, as far as either of you know, among elected officials about adequately funding and prioritizing COVID care and vaccination among incarcerated populations. So I haven't heard of any policies being brought down from county, municipal, or state governments. Perhaps I missed them, but that's certainly an area that journalists would want to explore as they look into this question. So if either of you know of any states or counties who've been dealing with this issue or have pushed back on it, it'd be interesting to know.
I'm not aware of pushback in that sense. Competition, yes, say, teachers unions or others who want to be up first.
Right.
How do you prioritize, right? But not policy pushback. Emily?
Where I would maybe turn attention is the National Association of Counties as well as the National Sheriff's Association. So, elected officials in both those groups have come forward supporting something called the Medicaid Reentry Act, which would enable Medicaid coverage 30 days prior to release. And currently, that would enable then payment for vaccination, payment for testing prior to release. This is one of our primary recommendations from the National Academy's consensus report, is that to decarcerate appropriately, you have to kind of make certain that they're not increasing transmission in the community. And so I haven't seen pushback. And in fact, I've seen support and looking for alternative ways to fund the care and preventive measures like vaccines.
Jake Hopper just follows up on that question, whether there's pushback that you might anticipate from correctional staff or incarcerees who might not wish to be vaccinated. I think one of you did touch on that very briefly, but I mean, obviously, people are incarcerated. They've lost their freedom in a lot of ways. I mean, can you mandate vaccination in an incarcerated environment, in the correctional environment?
No, Emily.
Not that I'm aware of.
Okay.
Oh, no. But it's interesting, even though I could share like influenza vaccination, right?
Right.
We're at big campaigns now to get people vaccinated. The uptake is not what you would think. It's challenging. There's a lot of mistrust and others, but maybe 50% is a success. So the different systems are trying different incentives, right, to get patients to agree for vaccination. I think we're gonna have to do some of the same creative tasks for COVID vaccinations when it's ready. There's been surveys looking at healthcare providers where not a large majority are even willing to take the COVID vaccine when it comes out. So it's really surprising when you look at that.
Yeah. I would say that, this is, not talking about our consensus report, but really just thinking about vaccination and vaccine hesitancy. I mean, Dr. May speaks about this, and of course they've done surveys of looking at kind of individuals of racial, ethnic minority groups, and their concerns are very valid about kind of being the first to be given, right? And so same with incarcerated individuals who are now being prioritized. What's this all about, right? Especially given the history of unethical research and practices and trying meds on these sorts of populations. And so what I would say is, there are examples, and, I've seen this implemented well, of places where correctional systems have found novel ways to distribute vaccines. And one example that we did hear about is where, for instance, the correctional staff and officers, and again, it just depends on the group, were the ones that got the same batch of vaccines, got the vaccine first, and then incarcerated individuals who saw the staff getting it were then more amenable to doing so. And so what it requires is listening. What it requires is really centering it on those individuals like Dr. May and his team that are practicing inside corrections, as well as those that are incarcerated, to say, what would make you feel safer? How best ought we to be distributing this? What are the ways that would make you kind of feel more confident about the vaccine? Because I think it's ridiculous to think that all of a sudden people are just going to start taking vaccines, and especially in a novel pandemic, they're the first to try it. That would just be naive. And so it's incumbent upon us as scientists, public health folks, and physicians to really figure out what are the best ways to do so.
I can see how you can systematize the process in prisons, in state prisons, but what about in jails? I mean, you have a daily turnover there, and how can you possibly assure that people who want to be vaccinated can be vaccinated, plus checking whether someone who's just come into the jail has already been vaccinated? I mean, the record challenge there would be enormous, I would imagine.
Exactly. No, and again, that speaks to, I was talking about silos, and the health departments really have to be integrated with these systems. Some participate in a statewide shot registry to track vaccines, and others don't. But, these are the questions that we need to work on.
So, Michael, can you read the other question from Victoria that we haven't asked yet?
Sure. So the other question is, I believe this is for Dr. May, but for the facilities that you serve, are your medical staff involved in evaluating people for medical release or compassionate release due to underlying health conditions and a risk of COVID-19?
Again, each system presents a different list of criteria of when someone may be eligible for those sorts of considerations, but then absolutely, if we've been asked to call through charts to identify lists of patients with certain conditions or at certain age groups, certain high-risk categories. So all that is being done. Again, it's sometimes, so the recommendations can be made, and then it sort of ends there, and it may result on other, parole board and others who make the decisions. And as Emily said, the social support system. And we've got patients who may be eligible for release, but where will they go? There's not something to hold them at the other end.
This is, I just wanted to at least turn similar attention to our consensus report, which found that, jails were able to decarcerate at larger rates than prisons. And one of the large reasons was that the compassionate release policies and kind of implementation practices aren't amenable to a pandemic. So even when there were physicians that were able to state this person should be released and meets criteria, and again, in our consensus report, we indicate that states have a lot of variability of compassionate release that isn't always in accordance with medical science and the vulnerabilities at the end of life. But even if you meet criteria for the state's compassionate release criteria, that then it goes through all these other bureaucratic barriers, and thus, at least by one study, and I think you guys are inviting this researcher to come and speak to you guys as well, only about 4% or 5% the state population incarcerated people within state prisons went down by 4 to 5% within the pandemic. So there are many executive orders to release individuals, and then they just couldn't be actualized. And so something that was pretty remarkable is the American Medical Association actually made a declaration that compassionate release mechanisms during the time of COVID, for the first time, were saying that they ought to be more in line with kind of physicians' ability to prognosticate what actually is at the end of life, and that physicians ought to take a larger role in getting these most medically vulnerable individuals out of prison.
So we only have a couple of minutes left. Let me ask each of you in turn to go back to one of the points I asked at the beginning. You said, what's this is not going to be the first pandemic that we're going to experience, unfortunately. Hopefully the next one won't be as bad, but it's unpredictable. So what lessons do you think that we've learned from dealing with this one that could be applied to correctional care in general and to dealing with infectious disease outbreaks? Maybe I'll start with Dr. Wang and then Dr. May.
Sure. So I think, I don't think it's a lesson learned. I think we've seen it before, but it's really been brought to the fore in this pandemic that correctional healthcare systems are deeply siloed, and as a result, it compromises those that work there, those that live there, as well as our communities. And in order to improve upon it, they have to be integrated within a public health infrastructure that is, administered, governed within the state or federal level, depending on the healthcare system. That's the first. And the second is that in doing so, it enables transitions of care. It enables transparency of data. One thing that we didn't talk too much about here is just that there hasn't been clear, transparent reporting of even the outcomes within corrections. And so all this is just the need for stronger infrastructure and supports and resources so that correctional systems can accommodate. The second thing I would say is that decarceration, our prison populations and jail populations are too large. And so to decarcerate and to continue to decarcerate, we have to create a social safety system in the community that best supports them. The healthcare system, our housing system, even our income support systems are too frail and fragile within a pandemic to really accommodate the number of people that need to come home to get the transmission rates down.
Thank you. Dr. May?
Well, I completely agree with all of that, so I won't repeat it, but certainly those as the priority. Followed by, I think, attention to architecture. I think we're recognizing more and more the importance of architecture in pandemics. We see, dormitory setting versus individual cells for ceiling height and UV lights, all that stuff. So our engineering and architecture is very important for jails and prisons. And then technology. I think prior to the pandemic, there was some reluctance for some facilities to modernize to, telemedicine, to let inmates or persons incarcerated to hold tablets and those sorts of things. That's all changing. And I think it opens up new opportunities for doing things better and smarter with better access to care.
Okay, I think we'll have to leave it there for the moment, but I want to thank both of you for, it's an incredibly difficult and complex subject to try to cover in just an hour, but I think there's some more questions. We haven't quite got to all of them yet, and we'll bundle them and send them to you. But thank you both very much for your time. We will, I hope you can stay with us if you can for the rest of we got one more session to go. And if you can't, we'll certainly stay in touch. And anything you want to provide further to the journalists, please let me know. We'll have links up in our resource page website. So again, thank you, and we'll take a 10-minute break and come back around 2 o'clock. Thank you.
Thank you.
Thank you.